Okay, thank you, Tim, for the very interesting montage from the Respond group. Some housekeeping announcement before we get started. If you have any questions during the presentation, please type them into the question and answer chat box in your Zoom control panel. The moderator will bring up during the forum, and we also have time for questions and answer at the end. You can also watch the live forum through YouTube Live Research Resources, Faculty of Medicine UITM, and you also link in the chat box. Yeah, so you can click, you can pass forward to friends and colleagues, and can view through the YouTube. Please fill up the attendance form link at the chat box or scan QR code at the end of the session. Actually, within 10 minutes of this before the session ends. For those who just joined us, please welcome. Now, I would like to introduce our moderator for this forum. Yang berbahagia, Professor Datuk Dr. Ahmad Ibrahim, who is an experienced research scientist with the Rubber Research Institute of Malaysia, and he was the director of Palm Oil Research Institute in Malaysia and involved in the Malaysian Palm Oil Promotion Council. He was the Vice President Research at CIRIM, CEO of the Academy of Sciences Malaysia, and Senior Advisor Malaysia for the Fraunhofer Research Germany. In a nutshell, he has made important contribution to scientific R&D, development and science and technology policies for Malaysia, writes extensively on science issues and is a regular columnist with the NST. Now I'm going to introduce our panelists. Our first panelist is Prof. Dr. Martin McKee, who is the Program Leader, Response Study, and Professor of European Public Health from London School of Hygiene and Tropical Medicine, UK. Prof. Martin held respected position in research directive tasks, academics, received outstanding awards. He was the director of the European Centre on Health of Societies in Transition, research director of the European Observatory on Health System and Policies, the former chair of UK Society for Social Medicine, president of the European Public Health Association, former chair of WHO European Advisory Committee on Health Research, Global Health Advisory Committee of George Soros Open Society Foundation, and a member of European Commission Expert Panel on Investing in Health. He is recognized as the most outstanding and productive researcher and most cited researchers worldwide by Thomson Reuters. He was an editor of the European Journal of Public Health, numerous editorial boards, and editorial consultant to The Lancet. Now, coming back to Malaysia, our second panelist is Dr. Faisal Izzuan Mustafa. He is the famous public health and general medicine physician, cardiovascular and diabetes disease unit at the Disease Control Division, MOH Malaysia. He obtained his Master of Public Health in Epidemiology and Biostats degree from University Kebangsaan Malaysia and subsequently accepted as a member of Academy of Medicine Malaysia. His field of expertise is the prevention and control of cardiovascular and diabetes diseases from public health aspects. He is currently involved in the development of policies and programs for non-communicable diseases in Malaysia. He is also actively involved in research in Malaysia, particularly about diabetes and obesity. Our third panelist is from UiTM. Associate Professor Dr. Fanaza Arifin is a family medicine specialist. She obtained her Bachelor of Medicine and Surgery from King's College London and further training as General Practitioner under the London Vocational Training Scheme. She is a Fellow of Royal College of GP UK, has 15 years of experience as family medicine doctor and 10 years experience as medical lecturer and researcher. She has supervised and graded many clinical master's candidates, was the HOD of family medicine, and current position as Associate Professor in the Department of Primary Care Medicine, Faculty of Medicine, UiTM. And our final panelist is Dr. Muhammad Rodi Issa, who obtained his Bachelor of Medicine and Bachelor of Surgery in Master of Public Health from University of Malaya. He is interested in biostats and clinical epidemiology, has over 10 years experience as a public health specialist, and advised numerous students, researchers, lecturers, and approach to the conduct of research and perform data analysis. Currently, he is the medical lecturer in the Department of Public Health Medicine, Faculty of Medicine, UiTM. Next, I would like to introduce the most important key person for response study in Malaysia. Dr. Nafiza Manasseh is a family medicine specialist. She obtained her MBBS from UKM and subsequently obtained her Master of Family Medicine in University Malaya. She has 17 years experience as family medicine specialist and 14 years experience as lecturer and researcher. She has supervised and graduated many clinical master's candidates, currently medical lecturer at Department of Primary Care Medicine, Faculty of Medicine, UiTM. She is also an honorary secretary of the Malaysian Association of Adolescent Health, MAA. Please allow me to invite Dr. Nafiza Manasseh as primary investigator of response study in Malaysia to give her short opening address. Welcome, Dr. Nafiza.
Assalamualaikum and very good afternoon. Thank you very much, Madam Chairperson, Dr. Maza Puspavina, for the very kind introduction. Okay, good afternoon to everyone, to everyone here, and thank you very much for being here with us. Actually, the purpose of this webinar is to share our quantitative response project findings. And before we start, I would like to share with you a little bit about background on response in Malaysia. All right. Okay. Okay. As we know that cardiovascular disease is the largest contributor to non-NCD burden, and hypertension is still the main risk factor, and prevalent of hypertension is still high in Malaysia, and we know that there is still the control is still a problem. Here is for the findings from the previous PURE study. We still see that there is a treatment gap in hypertension among Malaysian and also in Philippines, especially in low socio-economic individual. So this study, this RESPOND project, is a responsive and equitable health system partner on non-communicable disease. It is a multidisciplinary project which involves several components, and it was funded by Wellcome Trust and also Newton Fund scheme, and the partnership of this collaborator is from UK, Malaysia, and also Philippines. Actually, in Malaysia, it was initially led by our late Datuk Dr. Kadir Yusof. Our late Datuk Dr. Khalid Yusof. Okay, what is the aim for RESPOND project? The aim for RESPOND project is to improve management of hypertension in Malaysia and also in Philippines, and in doing so to build capacity to mitigate the rapidly increasing health and economic burden of non-communicable disease. So the first objective of this project is to produce robust and compelling evidence on the barriers to hypertension control faced by the low-income household in Malaysia and also in the Philippines. And the second objective is to building on a long-standing collaboration among the partners and strengthen the health system research capacity in Malaysia and also Philippines, and develops models and approach that can be used in other low and middle income countries later. And the third objective is to promote uptake of evidence within study countries and regionally to inform the development of pro-poor responses to hypertension and by extension other common chronic disease. Okay, in RESPOND, actually, we have two component, quantitative study and also qualitative. But for this purpose, this webinar, we're going to present the quantitative finding. Okay. All right. The research approach, actually, there are 4 states of Peninsular Malaysia were selected purposely for the geographic diversity and representative, and 2 districts was chosen between which is urban and also rural. Example here we can see from the this is from the Selangor, from Penang, Kelantan, and also from Johor. And actually, in response study, it a multi-stage sampling, and in each mukim, actually in each district will be selected, and head of the mukim or penghulu was identified for the engagement with the head of resident or ketua kampung. They call it ketua kampung within the mukim. And upon meeting with the head of the village or ketua kampung, the list of poor hypertensive patients in the village was identified, and this study candidate was contacted and invited to be in the study. And from the mukim, from the mukim we try to the sampling method is what they did is they do the what do you call that one? Each mukim they selected 3 kampung, and from each kampung we try to randomly selected around about 25 individual. So the inclusion criteria is the individual is the age between 35 to 70 years at screening, and living within the household expected to remain at the current address or location for at least about 18 months, and either a self-reported history or hypertension or self-reported history of hypertension or identified as hypertensive during the screening. And the exclusion criteria is individual with self-reported history of cancer or HIV. Okay. I think that's all from me. So without further ado, I think we can hear what's the finding from our presenter later. Thank you.
Okay, thank you, Dr. Nafiza Manaseh, for the quite enlightening opening address and explaining about the response study. Okay, without further ado, please welcome Yang Berbahagia Profesor Datuk Dr. Ahmad Ibrahim to start the forum. Title, Hypertension Among the B-40 in Malaysia, Results from Response Study. Please welcome Prof. Datuk Ahmad. I pass the floor to you. Thank you.
Thank you very much, Dr. Maza. I'm sure everyone is looking forward to hear the results of this very important study. We all know that sickness is a big cost to the economy. We can see from the pandemic how many economies have suffered from this public health disruption. And hypertension is dubbed by many as a silent killer. Many may not realize before it is too late. So vigilant disease monitoring is always a very important initiative. And it's clear that the B-40 group, the bottom 40% of the population, is seen as vulnerable group. So this response study will shed some light on the situation in Malaysia, which may help us craft the right policy, the right strategy to address the issue. To start off the presentation, I would like to invite Professor Dr. Martin McKee from the London School of Hygiene and Tropical Medicine, who is actually the leading person for this big study, to give us a presentation on the big picture and why Malaysia has actually been chosen and the Philippines as part of this big study. Please welcome Dr. Martin McKee.
Thank you very much indeed. And I'm going to try to share my screen here. And with a bit of luck, here we are. Right, so thank you for that introduction. Thank you very much to the team in Kuala Lumpur for organizing this webinar. And it looks to be very interesting. We're really looking forward to hear the results from the study. So as you've already heard, RESPOND stands for Responsive and Equitable Health Systems, a partnership looking at non-communicable diseases. And before I start, I'd like to just preface my words by paying tribute to Khalid Yusuf, who was our lead in Malaysia and was also a very good friend for many years. And tragically, of course, he is no longer with us. But I really want to dedicate this presentation, as we do with all of our work in RESPOND, to his memory. So you have already heard a little bit about this. And just to remind us, it is a multidisciplinary project. It began in 2018 with joint funding from the Wellcome Trust and the UK Newton Medical Research Council scheme, a partnership with the UK, Malaysia and the Philippines. I won't go through that because you've already heard the introduction to the project, but maybe I should emphasize why we are looking at hypertension. And if we look in the two countries concerned, and I just, can you see my screen all right? It's always difficult to know with, yeah.
Yes.
You can. So you can see that if we take the data from the Global Burden of Disease, the project that is pulled together by the Institute for Health Metrics and Evaluation at the University of Washington in Seattle, high blood pressure comes out as the second highest risk factor in Malaysia and the third highest risk factor in the Philippines. And of course, this is a condition which is easily treated. We have had the ability to diagnose blood pressure for over a century. We have had the ability to treat it with safe and effective medication since at least the 1950s, when initially beta blockers came in, and then ACE inhibitors and thiazide diuretics and other medications. So it's not difficult to do, but the problem is that we don't do it very well. And we can see that these are data from the PURE study, which you've already heard mention of. And you can see that in both of the countries, there are only there's a high proportion of people who are treated, diagnosed and treated. We're seeing that a very low number are controlled. Now, the one thing I would say about Malaysia, and this is a great tribute to Malaysia, is that you have a much greater degree of equity when we look at the differences from the rich to the poor. But clearly, people who are living in the B-40 communities are significantly disadvantaged in many other ways. But I think it is worth paying tribute to the achievements that you have made in Malaysia compared to many other countries that we've looked at, 25 countries worldwide in the PURE study. So what we're trying to do in Respond is to generate robust evidence with new data, and you will be hearing some of the results from the data. And we will be moving to comparative analyses looking at the two countries. We're looking at the quantitative data today, but let's not overlook the qualitative data where we have been trying, and it's been very challenging because of the technology, to get people to record their personal experiences. And also part of this is about building health systems research capacity. In Malaysia, you do have a great deal of strength there already. So we're looking at ways of building partnerships and looking at areas like training and communication and public engagement, which again, a lot has been done. And then, of course, the challenge of making sure that the findings are taken up, that we have engagement with stakeholders. And today's event is very much an example of what can be done there. So what we're trying to achieve, we're promoting pro-PURE, people-centered policies on non-communicable diseases, and looking at ways to ensure that poor people and communities and civil societies champion. We're looking at strengthening institutions, and we're looking at building sustainable links between Malaysia, Philippines, the UK, and internationally, because, of course, the answer to all of our problems is international collaboration to draw on our own strengths and to build these very important links in international research. The study design, well, you've heard a little bit about that. We're primarily focusing on the quantitative element, but of course we have other elements from interviews which we are analysing too. And just to remind ourselves, the settings are in Peninsular Malaysia, and I'm not sure if my toolbar is getting in the way there, but also we have sites in the Philippines as well. And you have heard a little bit about the sampling design already. I'd just like to say that this project has already been very successful. Here are some of the papers. We have the situation analysis from Malaysia, the protocol, and a number of papers that have looked particularly at the qualitative data, but we now have papers under review. And thank you to the Malaysian team that just submitted one of the other papers that's now under review, and we're hoping that we will hear about that soon. But this has been a very productive collaboration, and we're very grateful to our colleagues. So that's a very brief introduction. The rationale for undertaking this study is, I have to say, primarily because it builds on strong existing collaborations, and those were collaborations with Khalid Yusuf through the PURE study. And of course, the PURE study itself has generated an enormous volume of material, and it is continuing to do so with a new paper only just published this morning, in fact, which looks at the economic impact of COVID on people in different level, again, countries at different levels of development. So this is building on the PURE study, and we are very grateful to our fantastic collaborators in Kuala Lumpur. So that's a very brief introduction, and now I need to try to stop sharing my screen.
Thank you very much, Professor McKee. And it's good to hear that Malaysia is reflecting better degree of health equity. This is very good, and I think some of the results have also confirmed this. So let's get to the first part of the results, and this will be presented by Dr. Muhammad Rodi Isa from the UITM. Please welcome Dr. Muhammad Rodi. Dr. Rudi, please unmute yourself.
Okay, sorry. Okay, good afternoon. Assalamualaikum and very good afternoon to all. And good morning to Prof. Martin. Okay, the first part of the response study here, I have a result for the source of information for hypertensive among hypertension patient among B-40 group in Malaysia. This is the result from the B-40 study. And for the introduction, there are so many sources of health information, such as health facilities, like primary healthcare center, family, friends, television, print media, internet, radio, and traditional healer. And more than half of the general population use an internet to seek for health information. Although the internet is utilized more common, but the trusted source of information still need to be delivered clearly. And therefore, there is a challenge for modern healthcare services to provide easily accessible and accurate health information for the public and patient. So this study aims to determine the different sources of information regarding hypertension received and its associated factors among low-income individuals or B-40 group in Malaysia. For the methodology, I think I don't want to elaborate more on the methodology. This has been described by Dr. Nafiza previously. Then I go straight away to the result. So this is the result for stratified by receive information and do not receive the information. I think the 417 received the information. Those 194 did not receive the information. It got around 68% of the B-40 group did not receive any information about hypertension. So I still consider this is very high, right? So this is a comparison of the respondent who receive and do not receive the information. I stratified by location, cases, and all cases is they are higher compared to, significantly higher compared to new. Gender, almost the same, comparing male and female. Age group, mostly age more than 50 years old. Educational, not statistically significant. Marital status, no different. And how much they know about hypertension, mostly those who receive the information, they know better or very familiar about hypertension. And this result for the table 3, this is a source of information among hypertension and the control of blood pressure status. So here, the B-40 group, mostly they use the health facility, even though nowadays internet is everywhere. But this B-40 group, they still depend on the health facility to receive the information. When you look at the percent of control blood pressure, the highest is they receive the information from friends, 41%, family, and followed by the health facility. Right, and we can see here television, print media, internet, radio. This is more on the telecommunication, but the percentage is still lower, less than 10%. Okay, and then this is a comparison of the social demographic stratified by the source of information. When we look at this result here, there's so many interesting things, but I just focus on the significant part. Looking at the television, mostly rural area, they use television for the source of information compared to rural population. For the old cases, mostly they use health facility. Even though the old cases, they receive more on the family, friends, television, print media, internet, and also radio, right? For gender, mostly female, they receive the information more from health facility compared to male. For the age group, mostly those who age more than 50, they receive the information from internet compared to, age group less than 50, they receive the internet they receive the information from the internet compared to the older people. And this one is more stratified by the educational status, marital status, as how much they know about hypertension. All right. Even though there are not many studies found the significant findings, however, once you see here the how much they know about hypertension for printed media. So those who only heard about the term, mostly they received from the printed media. Right. Okay, for the discussion, having a reliable source of health information is vital to build a strong foundation of knowledge. And the percentage of the respondent who received information about hypertension was lower, only 68.2%. This is because nowadays the source of information, health information, is becoming more digitalized, making data collection easier and more convenient for patients and the medical personnel. That's why I consider 68% is still low. Then all cases receive higher information on hypertension than new cases in all sources of health information, because every time they went for follow-up, they get more information to monitor their overall health and manage any side effects from the hypertension. And healthcare providers are the first source of health information, and patients have better access to health care. Although physicians were preferred and highly trusted, internet sources appear to impact the medical knowledge of the population. Study by Molan, they found that 68.4% previously used the internet to acquire health information, and 25.4% consulted the internet for health information. And the study by Raymond in the Health Information National Trends Survey found more than 70% of friends and family were the most frequent sources of health information, which are associated with an increased self-report preventive behavior. There are few reasons why they receive more from friends and family, such as a lack of motivation and confidence in the treatment given by the health personnel. Therefore, doctor-patient relations need to be enhanced to increase patient satisfaction, greater patient understanding of health problem and treatment available, and providing support and reassurance to patients. So urban population use an internet slightly higher than the rural population, but not statistically significant. Yeah, there are many reasons why they don't use the internet, such as problem in internet coverage and availability, slow internet everywhere, one device cannot connect to Wi-Fi, the connection drop at random time, Wi-Fi network disappear entirely, and the network connect, but there are no internet access. So other reasons could be due to no smartphone and expensive bill. So therefore, the Ministry of Communication and Multimedia needs to provide some package to improve the network and reduce the internet bills. That older patients receive the information lowest from the internet, only 5.8%. Therefore, the government needs to increase some effects to help older people for better navigate and utilize the internet, so that they may increase their trust, thereby increasing satisfaction with their own ability to seek and use sources of health information. Okay. Television is still one of the important sources of health information, and rural population use more television compared to urban population. Because mostly in Malaysia, around every single house they have at least one television. Study by Department of Statistics found 97.6% of the household, they have their television. So therefore, MOH can make a suggestion to Ministry of Communication to spend few minutes to advertise the health information regarding hypertension for any communicable and non-communicable diseases on television more frequent. And the blood pressure control was not very good, because we found the control is less than 50%, where the information received from friends, 41.8%, and family members, 40% were among the highest. It is because they are communicating with each other most of the time. So the patient only receive a reliable health information from the medical personnel. However, they are sharing the information only during follow-up. Therefore, mobilizing family support was found an effective support for chronic illnesses management, and self-care without significant physical or cognitive disability among adult patients. The conclusions of this study found that the percentage of the respondents who received information about hypertension was low, and this population receives more health information on hypertension from health facility instead of internet usage. Therefore, medical personnel need to be more knowledgeable to deliver the information, mostly to the new cases of hypertensive individuals. Okay, I think that's all.
Okay.
Thank you.
Thank you. Thank you very much, Dr. Muhammad Rodi. Very useful output, data on information sources. And we can see again the role of the internet. This could be a big message to the authority to try and improve in terms of internet coverage and internet reach to the population. Otherwise, no source of information, if we're lacking in the source of information, this also can have a negative repercussion for the controlling of hypertension. Okay, thank you very much, Dr. Rodi. Next, we move to Associate Professor, Dr. Farnaza Arifin, who will give the next part of the result from the study. Please, Dr. Farnaza.
Thank you very much, Dr. Ahmad. So I'm going to share my slides. Okay. Sorry. Can everybody see my slides?
Yes, but it is a bit blur. Okay. Yeah, now it's okay.
Okay. So I'm going to talk about the knowledge of hypertension, treatment-seeking dynamics, and access to healthcare among the low-income B-40 individuals in Malaysia. So first of all, we know that better knowledge and understanding of high blood pressure and the importance of taking medication is crucial in managing blood pressure and achieving good control. However, there is still some lack of information regarding the hypertensive patients' knowledge among the B-40 communities. Also, if we look at the treatment-seeking dynamics, we can see that there's a question whether is there a disparity between the urban and the rural communities in terms of their access to healthcare. And this, if there is a disparity, then it can lead to inequality in terms of blood pressure management and control. So the objective of this presentation is to discuss the results from our response study. So looking at these two aspects of the study. So what I'm going to talk about is to discuss the knowledge on hypertension among the lower income community. Specifically, we look at patients' knowledge on the complications of hypertension and importance of medication. And then also to discuss the treatment-seeking dynamics and access to healthcare among the urban and rural low-income community. So these are the results. If we look at the knowledge of hypertension, if we compare to what Dr. Rodi mentioned previously, that actually most of our participants have some knowledge of hypertension. So that's quite motivating for us. Only about 14.4% thought that they were very familiar with hypertension, but none at all, meaning that they
they thought that they did not have any knowledge of hypertension at all was only about 2.7%. So that's quite motivating for us. However, the majority perceive that they have some knowledge, but perhaps we would prefer if they were more familiar with hypertension. So looking at what type of knowledge that they have. So majority of the participants, they were quite well versed with the fact that high blood pressure can cause stroke. I suppose this is something that we often as medical personnel would talk to them about, that high blood pressure and uncontrolled blood pressure can actually lead to stroke. However, they were a little bit unsure regarding whether high blood pressure can cause cancer. I'll talk about that in a minute. And then they also understand that high blood pressure doesn't necessarily mean that they will feel unwell. So they can feel well, however, their blood pressure can still be high. They also know that they cannot stop taking their medication, even if they feel well, and that they shouldn't just take the medication when they feel unwell. So all of those results are showing positive trends in terms of their knowledge of hypertension. However, if we look at this particular information, that they weren't sure, some thought that maybe it can cause cancer and some was not sure, they don't know. So perhaps we have to correct this misconception that actually high blood pressure does not cause cancer in our patients. Okay, in terms of the perception of health and long-term illness, so 65% of patients rated their health as poor, so they actually felt that their health was poor. However, 94.3% thought that they did not suffer from long-term illness. So this poses some questions in terms of the discrepancy between the perception of long-term illness, because it seems that our hypertensive patients did not think that the high blood pressure as a long-term illness, perhaps because they don't feel unwell. However, they still regarded their health as poor. So maybe this information is something that we can identify in the qualitative aspect of the study as we explore why do they perceive their health as poor, but yet not perceive hypertension as a long-term illness. So when we look at the comparison of the Western medicine and the traditional complementary medicine, most of our participants, again, this is quite a positive thing for our participants. They actually believe that the Western medicine can control their blood pressure, so 76.1%. In terms of the TCM, most actually do not see it. Well, there's a varying results there in terms of how many actually believes it's effective and how many believe it's ineffective. So 23.7% believe that it is ineffective. However, some do not know, and then some believe that it might be effective. So perhaps this is something as more information should be given out there to inform the patients that the TCM is probably not the best treatment for high blood pressure. Okay, so in terms of the modifiable behaviors that can improve blood pressure control, so this is quite a positive response, because 92% say that taking less salt will be effective. 87.5% thought that increased physical exercise is effective. 89.8% also thought that reducing stress can be effective, and also 83% thought that losing body weight will be effective. So these are all important modifiable behaviors that can improve blood pressure, and they seem to understand that these activities can actually reduce their own blood pressure. Okay, when we look at the comparison between the urban and rural and the access to healthcare. So the question that I posed at the beginning, so is there a difference between treatment seeking dynamics and access to healthcare between the urban and rural? Actually, I think Prof. Martin mentioned this right at the beginning, that there is no difference between the two, and this is seen in our results, that the treatment-seeking dynamics and access to healthcare is quite similar between the urban and the rural population. If we look at the main reason as to why they first visited to check for their blood pressure, is actually quite similar in terms of the urban and rural, that almost half of them went to see the doctor because they were worried about their blood pressure. So they have some awareness about the blood pressure and worry that they might have high blood pressure. The majority seek the health personnel because it was convenient and nearby. So it seems that the patients, they will go to the clinic or the health facility that is more convenient and nearby to their homes. The main facility chosen were government clinics. That's about 40.9% in urban, a bit less in the rural facility, 29.1%. And private health clinics, there are more attendances, so 69.8% in the urban and 67% in the rural. Most thought that they didn't receive any information on high blood pressure before the diagnosis was made. So Dr. Rodi talked about after they have been diagnosed, but before the diagnosis, most felt that they didn't receive the information. So about 56.5% in the urban and 62.4% in the rural. And that their pre-diagnosis were informed mostly by the general practitioners. It's about 15.8% and 14.4%. The rest were distributed amongst many various facilities, either government or hospital and so on. Most were advised for diet change, weight reduction, and increased physical activity. So perhaps this was the reason as to why they have quite good knowledge that I presented earlier on, because they were advised regarding the lifestyle modification and changes. If we look upon the diagnosis and treatment, so after they have been diagnosed and receiving treatment, so the majority had prescribed with the modern medicine. That's quite a high percentage. So urban 86.5% and rural 91.4%. The different medication types, this follows the guidelines. So that's quite good to know that our healthcare professionals are following the guidelines with the primarily CCBs, amlodipine, followed by ACE inhibitor, for example, perindopril, and then beta blockers and so on. So the guidelines has been disseminated in terms of the practice of our healthcare professionals. For the sources of information, so the source of medication were from the government or private clinic, and then mostly was not advised for traditional medicine. So the message is coming across regarding the TCM and also the adherence to the Western medicines. So in conclusion, actually, the primary care medicine health clinics, government clinics are still the main source of information for our patients. So a little bit on the discussion. So we know that the government policy has taken steps to ensure the equal access to healthcare by having the klinik kesihatan in urban and rural areas. In fact, the policy denotes that there has to be a klinik kesihatan within 25 to 50 kilometer radius within an area. And this is for both urban and rural as well. Also, there's the government policy in terms of training more specialists and placing the family medicine specialists in the klinik kesihatan in both urban and rural areas as well. It is estimated that the country needs about 8,000 FMS. Currently, I think we have about 900. Correct me if I'm wrong. I think Dr. Faisal knows more about this. But basically, we're still not quite there yet in terms of having the 8,000 specialists in the clinic kesihatan. There are also policies to encourage healthy lifestyle, including salt reduction strategy, 10,000 steps per day, 150 minutes of exercise per week, and focusing on mental health and stress management. So hopefully that all these steps are being disseminated to the patients so that they can do something about it to improve their blood pressure control and general well-being. Also, it's important for the doctors to tackle some of the misconceptions around the knowledge of hypertension. For example, the misconception about cancer just now, and also TCM, and to encourage the adherence to medication. So in conclusion, knowledge perception among lower income is high. Could be better if they felt that they knew more, but most of them felt that they knew something about hypertension. Some misconceptions need to be addressed. Knowledge needs to be linked with action and change in behavior. So they seem to have the knowledge, for example, reducing salt, increased exercise, weight loss, and stress management. However, how do we translate this into action? So patients do not perceive hypertension as long-term illness, but perceive health as poor. So why? Something that we will explore further. And there is similar treatment-seeking dynamics and access to healthcare between urban and rural communities. Primary care, such as government health clinics and GP clinics, are still the primary contact for patients in terms of seeking diagnosis, information, treatment, and follow-up. So it's important for the doctors to be able to advise patients accordingly. So with that, I thank you.
Okay, thank you very much, Dr. Farnaza. I can see there are a number of very positive outcomes from the studies for Malaysia, but there are still a few gaps that need to be addressed. Maybe looking at the policy, can we now invite Dr. Faisal Isham Mustafa, who is actually with the Disease Control Division, to shed more light on how the government is dealing with this hypertension issue. Please, Dr. Faisal.
Thank you, Dr. Can I just clarify? I think there's a third presentation from Dr. Rodi. First, am I correct?
First, Dr. Rodi, then Dr. Farnaza, then yours.
Is that wrong, Rodi?
I think I need to talk about the undiagnosed first, then Dr. Faisal, followed by Dr. Faisal.
Oh, I see. There is another. Okay. You can give your presentation now, Dr. Rodi.
Okay. Good afternoon. We see again. So first, we're talking about information. Then we're talking about the knowledge of hypertension among B-40 group. So, I think from Panaza say that knowledge is very high among the B-40 group. However, we still have the undiagnosed. Why this happened? So the title of my study is the undiagnosed hypertension among low B-40 group individual in Malaysia. Right. The prevalence of no hypertension has resulted from the progressions of undiagnosed hypertension, and it was estimated that 46% of adults were unaware with hypertension. In Malaysia, in National Health Mobility Survey 2019 reported that the prevalence of undiagnosed hypertension was 14.1%. And there was a significant association between undiagnosed hypertension with health and economics burden. So the aim of this study is to determine the prevalence of undiagnosed hypertension and its associated factor among B-40 group in Malaysia. Okay, I don't want to repeat back again, the methodology has been described by Dr. Nafiza previously, and this is the result for the social demographic difference between diagnosed and undiagnosed and known hypertension. So 93 respondents from 611 had undiagnosed hypertension. Right, this is just a descriptive result. And this is the univariate analysis, univariate analysis before we proceed to the multivariate analysis to determine the factor associated with undiagnosed hypertension. So from this study, we found that the age group more 50 years old and above is the factor. Tobacco use, current tobacco use, mean blood pressure, and those who don't know that they have the diabetes mellitus is the factor for undiagnosed hypertension. So goes for discussion, 15.2% of the individuals, I think I missed it, B-40 group were undiagnosed hypertension. The percentage is slightly higher compared to the National and Mobility Survey in 2019. It could be due to the lack of awareness, why the prevalence was high. That lower income individual, a study by Hannah, she found that the low income individual were 3.5 times more likely to have undiagnosed hypertension. Therefore, the intention needs to be taken to overcome this problem to reduce the prevalence of undiagnosed hypertension. From this result, we found that 43% of the respondents were aged 60 and above. And this study found the age group 50 to 59 years old will be the significant factors compared to the age group is less than 50 years old. It could be due to did not manage it adequately and lack of engagement of their health condition. And this study found that those respondents without diabetes had a significant association with undiagnosed hypertension. And hypertension and diabetes are sharing a common risk factor, and mostly those without diabetes, they did not go for any health screening, so they didn't know about their hypertension status. Therefore, screening and effective treatment of hypertension should be considered as an important goal by healthcare experts and the community health nurses. 31.9% current tobacco user was undiagnosed hypertension and be the associated factor. Then smokers are less likely to seek for health seeking. Therefore, government needs to revise the tobacco policy. Systolic blood pressure was found to be associated factor for undiagnosed hypertension. Therefore, home blood pressure monitoring can be incorporated into the care of patient. So goes to the conclusion, the prevalence of undiagnosed hypertension was high, 15.2%, and improving the individual general awareness and screening for hypertension, mostly among elderly, are necessary for timely management. Tobacco policy need to be revised by the government, and home blood pressure monitoring can be incorporated to the care of patient, and regular follow-up can be offered for early treatment. I think that's all. Thank you.
Oh, thank you, Dr. Muhammad Rodi, for that very concise presentation on diagnosis and undiagnosis. Okay, next we have a very important speaker for all this, because what matters eventually is the policy. What policy we want to put in place to address some of the gaps. And to do this, I would like to invite Dr. Faisal Isam Mustafa. Please, Dr. Faisal.
Thank you very much, Yang Berbahagia Prof. Datuk. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good morning, good afternoon, good evening. Thank you very much, Prof. Martin, Rodi, and Farnaza for that presentation. I've been involved somewhat indirectly since the start of the journey, being roped in by Arwah, Prof. KY as well. So I would like to pay my tribute as well for the work that he has done. So what I've been requested by the organizer is to do a wrap up or summary of what have been presented from my perspective, from where I am right now, working in the policy making space. So firstly, and this is more for the young researchers out there. One of the things that you would need to think about when you think about this kind of research is to engage, to know who your key stakeholders are and to engage them from early on, which the researchers for this project have done. They have involved me from early on. Involvement more like updating me of progress and updating me of some. And in fact, the actual inviting me to be part of the panel is part of the important advocacy work for you to see the output of your research being put into practice. Just allow me, I've got some slide to share. I think just to illustrate some of the points that I like to make. My first point is talking about implementation science. While research like RESPOND, for example, may provide the evidence for some setting, some interventional studies as well. What I like to see more is the work in the implementation science itself, is to study how programs get implemented into practice and the quality of implementation, and how the quality of the implementation may affect how well that program work or do not work. Just as a recap for some of you who may not or may be aware or not aware of the current NCD burden in Malaysia, the latest National Health and Mobility Survey was done in 2019. The next one will be in the year 2023. The next year, we do it every 4 years, shows an increasing burden for NCDs, and I've highlighted the burden for hypertension there. So when we talk about the NCD prevention control, in this case, we're talking about hypertension. So while the group, just the researchers have mentioned, there is a qualitative component and a quantitative component. And what they have presented today is more in the quantitative components, but it still looks at behavior. And behavior is something that I strongly feel is not being looked at in more detail within the context of Malaysia. Okay, so going back to what I would like to show here, when we talk about prevention control, you can replace that with the NCD with hypertension. You would need to think about the actual prevention itself, then early detection, the diagnosis and management, the thing in the middle. You talk about rehabilitation when patients develop complications, and then palliative care. All right, so that's the whole continuum. Sometimes we just focus on the provision of services. We keep asking, what does MOH doing for this? What are we doing for that? But yet, what we don't often not look at is the demand component. And this is pretty unique. This is, what the demand is in the UK will be different in the Philippines, will be different in Malaysia. This is very, 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 just to emphasize the importance, that context specificity. It depends on the socio-economic group, it depends on your ethnicity, your religion, your belief systems. In fact, because you can offer a lot of things, but if the patients do not want to engage with what you're offering to them, then it comes to naught. Okay, so the behavior of individuals, especially why Malaysians do the things that they do, really. And just to add on to what have been presented, this is more general. During the NHMS in 2019, they also assessed the level of health literacy of Malaysians, adult Malaysians. This is using the tool which I've stated on the slide itself. And we found that 1 in 3 adults in Malaysia have low health literacy. So literacy is not just about awareness and knowledge. It's about you being able to understand that particular knowledge and to use it for decision making and for actions as well, right? So that's the more simplified explanation what literacy means. It's not just about your knowledge. Just to share again, a work that my team have done looking at diabetes patients. These are type 2 diabetes patients. In terms of their preferred source of information, I'm not sure whether my team have published. I've asked them to do this publication. So we did this as part of the program, not so much research, but we wanted to understand our patients. So, and just to put things in context, the patients, the type 2 diabetes patients that come to our health clinics are usually in the older age group. And this research was done in urban health clinics, klinik kesihatan in urban areas in several states. And you would see there are a lot of similarities with what the researcher from Respond have found, that in terms of face-to-face, healthcare providers still feature prominently. Traditional media, it's not surprising when you think about their mean age group for diabetes patient seeking follow-up in MOH health clinics. New media, and one of the reasons why we did this quick and dirty survey is because people keep pitching us about apps. There's so many apps out there, and we just wanted to highlight about 9.2% of our patients would be keen on apps. So I'm not saying don't do apps, but we need to, like I said, understand the perspective of our users, and that is our patients, and clients, and that is something which I feel is very important. Looking at the bigger picture, why B-40? I think we need to understand as well, our exposure to NCD risk factors are not the same. And we do know one of the main determinants of health is your socio-economic group, right? So in Malaysia, we use the B-40 terminology. And when we talk about diagnosed and undiagnosed, again, NHMS have highlighted that for hypertension, for high blood pressure itself, for everyone diagnosed, there's another one who is undiagnosed. We need to think about these three components which I like to highlight. Firstly, about patient empowerment for self-management. Secondly, about the activation, I use the word activation of healthcare providers as well. We need to think about, knowledge, they just evolve so fast. If you look at COVID-19, there's new knowledge coming out every day. Of course, for hypertension, it's not that fast, but you need to keep yourself updated. So we need to see how we can activate, as it were, our healthcare providers to be able to access information for them to increase their level of knowledge, be able to deliver quality care, and access for multidisciplinary, a platform of multidisciplinary professionals. And thirdly, talking about community awareness. So the first is more like individual level, and the last, community awareness. I put in brackets digital tools because I see them as tools, right? And digital, there are many ways to deliver quality care. And of course, everybody likes to talk about digital health nowadays. I like just people to take a step back, not just to think about the technology itself, but how people, especially the B-40 population, wants to engage with the technology that we would like to offer to them. Just because we have a digital health solutions that we think is cool, I use the word, doesn't mean that patients think they are cool, right? So we need to understand this so that when we do develop an intervention which is digital health in nature, they would want to engage with that. That's it in terms of what I would like to highlight. I would like to share with you. I congratulate the researcher in Respond for the work they have done. I think there is still a lot of work that we need to do. I'm very interested for the qualitative component. And we talk about qualitative component, you have the different components as well, right? You don't just look at the research patients. We need to look at people delivering the care, the doctors, the nurses, the other categories of healthcare professionals as well, and my behavior as well. I'm still human. And behaviors of policymakers. What drives me to make certain decisions? You have to understand, people do not make decisions just based on awareness and knowledge. Let's be clear on that. Our behavior is strongly influenced by the environment that we live in, both physical environment, spiritual environment as well. And it's the same for policymakers as well. Our behaviors are very influenced by our environment. And in which case, for me, it will be the political climate, as it were. I'll stop there. I look forward for the Q&A. Again, thank you very much to the Respond team for having me. I pass it back to you, Professor Dato. Thank you.
Thank you very much, Dr. Faisal, for that very crisp analysis and presentation about the whole issue of health management This is the first time I hear there is such a thing as supply and demand in the health services. Very interesting. And of course, you have always emphasized on behavior. Anyway, now we go to the questions. I'm not sure from the host, do we end at 4:45 or we can go on for a bit? Because 4:45, we only have 4 minutes.
Yeah, I think we can allow 2 or 3 questions.
Important 2 or 3 questions.
Yeah.
Okay. There is one question, very interesting question here for Dr. Faisal. And you did mention also in your presentation about this digital intervention. Is there any plan for testing for the B-40 group? Dr. Faisal, you may want to respond to that.
Okay, thank you very much. We need to look at the digital health in the broadest definition. I felt that COVID-19 has accelerated that. So now you would be able to see, for example, online appointments being made. I know that's not unique in the UK, but it's pretty new here on our part of the world. Teleconsultations being pushed as well in certain health clinics. Perhaps the adoption is more prevalent, more advanced in the private sector in Malaysia compared to the public sector. Because there's this both public and private. There are several projects that's being pushed by several stakeholders. From us, we are working, for example, with the UK government through the Prosperity Fund Better Health Program, again, to look at digital health intervention. So there are many people who are interested, and I hope and we will support, but at the moment, we have not gone beyond that service delivery, it's more of service delivery. I wouldn't say we have looked at more of the patient empowerment tools in terms of apps or anything similar. But there is space there. And I would urge any of you who are interested, we need to, when we do want to try it out, please look at the behavior component as well. Don't be so much on the technology side. And feel free to reach out to me as well through LinkedIn, and you will see my updates. So basically, there are some work being done, but there is space to do much more.
Okay, thank you. And maybe we can go to Prof. Martin. There is a question specifically for you. Somebody is asking, can you please share some methods to provide relief to hypertension? Prof. Martin.
Well, that's very much what the study is trying to do. And well, we actually have the answer to that to some extent. And we have, and again, paying tribute to Khalid, the Hope For and the team, because we did the Hope For study in Malaysia and Colombia. And this was an intervention where we worked with many of you here to develop an intervention in that combined a combination of therapy, peer support, which was very important, simplified guidelines, and task shifting to mid-level health workers. Now that paper, it was a cluster randomized controlled trial published in The Lancet, and that showed a very significant improvement in blood pressure control. So we, in a way, have the model of care that can work. Of course, the challenge, as Dr. Faisal has said, and others, we now need to implement these things in practice. And the challenge then is scaling that sort of thing up. But I think we do know what to do. The challenge then is building on what we've already heard, the evidence here, to look at the particular barriers that people face and tackling each of those barriers. Because as has already been said, the answers are different in Malaysia, from the Philippines, from the United Kingdom, from elsewhere. But we have got evidence of what works in Malaysia, which is unusual because there aren't many other countries where we do have that high quality evidence.
Thank you. There are actually a number of questions quite linked to each other. But maybe I can ask Prof. Maki, what's next after response? What further study we need to go into?
Well, Respond is embedded within Pure, and of course, as was Hope For. So I think there will still be a lot of work to do. We're following up a lot of people in Malaysia. Your team are following up a lot of people in Malaysia, and I think I know my colleague My colleagues in Canada who are leading on that work are looking at how the cohort that you're following up is aging. And then we look at issues like cognitive decline and stroke and things like that. So I think there will be a continued international engagement in non-communicable diseases between the Malaysian researchers and colleagues elsewhere, but largely based, I think, on the PURE study.
Yeah, okay. Yeah, a few questions, maybe anyone in the panel can respond. I combine some of these questions. One is whether hypertension can be completely cured, and a few other questions, any recommendation for programs that would improve the incidence of